Well, good morning, everyone. And on behalf of Michael and President Ginther, we welcome you to what I believe is our third meeting in this series as a task force. We're back at the Columbus Public Health, which is a great venue for the work that we do, not just because of the size of the room and its ability to accommodate us, but because of its locus in terms of support of health in our community. Wow, I just became the voice of God. I wish my husband could hear this. Our work continues to get a lot of attention. Most notably, I think many of you are aware, and we were very excited to hear Governor Kasich acknowledge the work that our First Lady of Ohio, his wife, is doing with us in his recent State of the State address. And the First Lady is scheduled to join us later. She actually had mommy duties this morning to drop her girls off at school, so she'll be in a little later. And yes, it is 8 o'clock or slightly after, so we apologize, but most of you start work at 7:30, so I'm sure it's not a great imposition. Just Mike Fiorelli and I at a little later hour. We've learned quite a bit, I think, in the 2 meetings that we've had thus far. We have great sensibilities about how far we have to go and the work that's ahead of us. We use terms like our rate being twice that of New York City, which is not intended to disparage New York City, but being such a larger, more robust community in terms of its diversity and the dynamics, it is a benchmark for us to be thoughtful about. And we are always reminded that we have nearly 150 babies in this community that we lose each year. And I really appreciate the way President Ginther framed that for us in our first session. When I think about 5 kindergarten classes that will never be convened because those children are no longer with us, that is chilling for me in that regard, and I think for all of us. So we have to remind ourselves of this each time we come together, not to be depressed or discouraged, but to be encouraged around the opportunity that we have before us. So in addition to gaining an understanding of the magnitude of our problem, we've learned a few other important items. First, I was really reminded of the importance of the health of girls and women in our community, well before thinking about pregnancy, at the point when they are adolescents. And, you know, we don't think about the proximity of the issue of the health of our girls in terms of this issue, but now we have to start thinking about that very early on. Another point that has hit home with all of us, I hope and I believe, are the social factors, the social determinants of health and impact in this arena. Poverty, in the broader sense, specifics around housing and education, hunger play a tremendous role in this issue for us. And neighborhoods. We've really learned that neighborhoods really matter. Not that we didn't think neighborhoods mattered, but we can't separate the importance of having a focus by neighborhood, by community, if we're going to make changes and make sustained improvements. And doing it in such a way that we engage the communities so that the interventions and the support is sustainable. Race. Race is a big factor in our ability to move our numbers and to move our community forward. And even if we accomplish our goals as we've stated them, we may still have more black babies dying. So that tells us the work will not be over even if we meet our goal of cutting that disparity in half, which is also a very chilling thought when you think about it. Prematurity and sudden and unexpected infant deaths are a big part of this, but what we have to do is be certain that we're looking for the determinants that drive the disparities so that we don't solve the problem at the macro level, or we think, and not really get at the micro level in sustainability around race and racial disparities. And finally, I really enjoyed seeing the data and the stories in the gallery walk. I think that was an informative way to come to grips with what's going on in our neighborhoods, and especially around housing, employment, safety, and education, and even the disparate outcomes for babies. When Mark pointed out that these were all the same families, that had not dawned on me. And so the reality of that one family could be impacted in this way is not lost on any of us as a result of that. So we've got a lot of work ahead of us, but we've got a lot of good information being brought to the table. And so I'm going to turn it over to Mike to continue us on our journey for this meeting.
Thanks, Donna. We're going to start this morning by having you take a look at our key driver diagram. Also, we're going to take a look at tab 5, which is a brief overview of our perinatal periods of risk, PPOR. You got to hang on to all these letters here with us this morning. We've heard speakers in our last 2 meetings refer to this, and we wanted you to be aware of the results of this analysis in our community. Without going into too much detail, what we can tell you is that our PPOR affirms this key driver diagram. In fact, it informed the development of our key drivers and the content of these meetings as we go forward. As you can see from looking at Franklin County's map, 42% of fetal and infant deaths are for babies who weigh less than 3.3 pounds at birth. PPOR identifies this as the maternal health and prematurity period as the key risk factors are most closely related to a mother's overall health, even and particularly before she conceives. That's what today's session's about, the first in one of our deeper dives into solutions on specific drivers, starting with women's preconception health. We'll also be considering the important issues related to pregnancies that are unintended. We'll consider important data around family planning and making safe choices, particularly for teens in our community. We know, as we've heard from some of you, that some of these topics that we'll discuss this morning can be sensitive. And we also want you to know and ensure you that all the viewpoints will be respected throughout this process. We also feel strongly that our deliberations and recommendations must be based upon data and evidence that exist and, in fact, what works. So today's conversation will be structured around exactly that.
So before we get started, I need the voice of God again. Before we get started on our segments and our conversation, and I'll just remind everyone, our speakers want us to be engaged and engaging, so no hesitation on asking questions. But I also want to acknowledge and thank the public, the folks who are sitting around the room, learning as we learn, and engaging with one another as we try to get the work done of the task force. I want to remind everyone that we still have a series of focus groups that we are in the process of conducting, also engaging in a number of neighborhood conversations. The public forum will continue, and toward the end of the work that we're doing, before we reach our final recommendations, we will have a public forum where we will engage the public in providing input and their thoughts on these recommendations. So we want you to continue to engage and look out for on our website the neighborhood forums, the group engagement that we are having, that we plan to continue to have, because your insight and your thoughts are important. In addition to your participation by being a part of this forum and learning what we learn and understanding what we come to understand as we do and as we bring these experts into our community. We know that there are many organizations and individuals that have tremendous insight into the challenges of infant mortality in our community. And President Ginther has made central to our charge is to make sure we do engage in a meaningful way with you. And so please keep your eye out either on our website, and also I think it's for the task force members, we're also asking that you participate in these community forums. And in your books behind tab 3, don't look at tab 4. There's nothing in tab 4. That was a trick. And behind tab 3, the very last few pages of tab 3 are a listing of some of the forums that have been set to date. And you could find those forums from a public perspective on the website. So we're also not just encouraging, but assigning you as task force members to select one or more of those to participate so that we're all hearing these different perspectives. And let's not wait until the public forum prior to the recommendations that will come back to you to engage in that work. So let's see. I'm trying to make sure I've covered all of the important housekeeping items. I think I have. One housekeeping item. I wanted to see if President Ginther, if there's anything you'd like to add before we get started on the main points of the program. You can have the voice of God.
Okay.
Turn it on.
Gotcha. Thank you, Donna, and thank you, Michael. I think the only thing I would like to add and ask for input from members of the task force this morning, one of the things that I mentioned to all of you when I asked you to serve on this task force was that we would remain engaged and solicit feedback as we were going through the process. So I know the co-chairs actually designed the agenda today based on some response and feedback that we gave through the initial part of that process. And it's going to be, I think, very productive and make today's meeting that much more meaningful and impactful. But I also wanted to open it up for a few minutes this morning to see if any of the task force members had any feedback, thoughts that they'd like to share with the collective group about how the process is coming along, if there are any ideas or suggestions for moving forward, just to start that dialogue. Feel free to jump in. Mark?
To review is very helpful.
Thank you. Well, we'll make sure to continue to engage, and actually Donna, Michael, and I were talking earlier, and we're going to reach out to each member of the task force individually and follow up to ask for any feedback if there are topics or issues that we're missing. The key charge and the reason that this collective effort is so different and so unique is that we're trying to deal with this in a comprehensive, inclusive way because we know the issue and challenge before us is daunting, but this group, based on everything that has been brought to the table, the outstanding speakers locally and nationally that have been brought to Columbus to share and guide our work, we feel very, very confident and comfortable that we're going to collectively reach these goals together. So it's important to hear from you as we're going through this process, and just want to underscore Donna's comments about the importance of having your presence and commitment at the neighborhood and stakeholder meetings so that we make sure that those views and feedback are brought into our mindset and our approach when we consider final recommendations that we're going to present to the community. So thanks again for your commitment. I'll turn things back over to Donna.
Okay, so thank you, President Ginther. So let's begin our work for today. We have a facilitated panel, so there will be more talking to you, but with your engagement, we'll be talking with you. The panel will be facilitated by Dr. Kelly Kelleher, Vice President of Community Health and Services Research and Director in the Center for Innovation in Pediatric Practice at the Research Institute at Nationwide Children's Hospital. He is a pediatrician and a health services researcher focused on improving and measuring the quality of pediatric care for high-risk children affected by social determinants of health, violence, neglect, alcohol, drug use, or mental disorders. So he's a kind of fun guy, too. Don't let all this title and stuff make you think he's, you know, he's going to be like watching paint dry, because he's not like that at all. So we're pleased to have Dr. Kelleher with us, and I'll go ahead and turn it over to him. Don't make a liar out of me.
You promised not to tell. Good morning, and thank you for this opportunity this morning. I actually don't want to spend a lot of time being fun today, because we have some expert panelists here that are really going to help us out on these important problems. And so thank you for your commitment to this issue. We have a lot of serious work to do. And in response to the task force, we want to get towards where we can go as a community to start to fix things. So our panelists are prepared to answer your questions, and they have some ideas about where our community needs to move, so I hope you'll push them on that. The format for this morning and the purpose for this morning is to learn, as we've already heard, about preconception health and intraconception health. And that is, before our young women are pregnant, what kind of health care do they need? What kind of health status do we have, and what can we do about it? Why is that important? What are the barriers to that in our community, and how do we fix it? So very simply and very straightforward how we do that. I am going to ask each of them to introduce themselves and say a couple words as they introduce themselves about their knowledge and their ideas. You have some materials behind tab 2. And there are materials behind tab 2. I've already checked. So we're good there. But I don't think you'll need to review them now. I think they're going to discuss them briefly. If you want to have them in front of you, that's great. And more importantly, I hope you'll bring your questions to bear. They have diverse expertise and thoughts on the process. After they say a few words, I have a question or two to start us off, but we will welcome your questions more than my questions, so please feel free to chime in. And then there will be a table exercise to follow that, and if they're able to stay, we're going to ask them to join you at your tables as well during that table exercise to start to talk about where can we go as a community. Okay? So, I'm going to go ahead and start. Ed, why don't you begin?
Sure. Good morning, everyone. My name is Ed Funai. I'm a maternal fetal medicine and OBGYN by training, but I spend most of my time serving as the Chief Operating Officer for OSU's health system. My background and my professional career has primarily been in New York and Connecticut, and I've been a participant, sometimes directly and sometimes indirectly, in the journey that you all would like to embark on. I'm relatively new to Columbus. I've been here 2.5 years, and I quickly realized that this community is blessed not only with a world-class children's hospital, but 3 outstanding health systems in town, a very top-notch cadre of maternal fetal medicine docs, and a close-knit obstetric community. But as you can see from the numbers, that is not enough. This is not a medical problem. This is a community-related problem, and only community solutions will take you where we all need to go. I want to talk to you a bit about both 2 important periods of time in a woman's life, in her reproductive life, and that is preconception care, which is care prior to pregnancy, and prenatal care, which is care during pregnancy. Preconception care, I think, is the cornerstone of what we'd like to achieve, although it can be a very challenging thing to strive for, because, as you know, nearly half of all pregnancies are unintended. But in an ideal world, preconception care can help to address long-standing medical issues that are a direct threat to the fetus. For example, poor control of diabetes, and we know that's increasing in prevalence, can result not only in prematurity or in macrosomia, which is an excessively large baby, but can contribute to congenital heart disease in the newborn. If you tightly control that diabetes prior to the time of conception, the outcomes are virtually normal. Likewise, there are very common problems, medical problems that many women experience, such as hypertension or epilepsy. Hypertension, especially in African American women, tend to be treated with drugs that can be very dangerous to the fetus. It's very easy to switch those medications in anticipation of pregnancy. We can avert problems if we're thinking proactively. The message that I've tried to send not only to women but providers, and we're talking about not only obstetric providers but internal medicine, family medicine, primary care physicians, is that there's really one simple rule. If a woman is taking a medication every day, whether it be illegal or legal, she merits preconception care because there's a decent likelihood that either the condition or the medication itself can be a threat to the pregnancy. And it's like anything else. If you're going to go on a long car trip, it's better to get your car tuned up and checked out before you go. Same thing, pregnancy is a 9-month period of stress for the mother, and it's ideal to optimize her health prior to conception. Prenatal care obviously is care during pregnancy, and if provided early enough, can actually achieve many of the same benefits as preconception care. It can help us to identify the women at highest risk for conditions that you've just heard about, like prior preterm birth. There's a little secret in medicine when we talk with medical students. We ask them what risk factors are for certain conditions, and usually the greatest risk factor for anything is prior something. So the greatest risk factor for future preterm birth is a prior preterm birth. And fortunately, over the last 10 years, we have a medication called progesterone. It's a natural hormone that can reduce that risk by as much as 40%. What we need to do is identify women early enough in the pregnancy, by 15 or 16 weeks, such that we are able to give it to them where it has maximal benefit. Prenatal education is also a very important aspect. It's not just medical treatment. I found from my own experience, and there's a body of literature, that pregnancy is an extended teachable moment in a woman's life. So I have seen dozens, if not hundreds of times, situations where women have serious lifelong problems with addiction, be it illegal drug use, tobacco use, and they are able to lick that problem at least during the period of pregnancy for the benefit of their baby. Obviously, it's a very powerful emotional motivator that we need to take advantage of. Related to that, though, and I should mention with smoking, well, this is a difficult problem as well. When you look at the data that was shown early on, you have to note that 1/3 of all low birth weight in this country and 1/3 of all SIDS deaths are smoking related. So that's a nut that we can crack that's entirely preventable. A lot of SIDS and a lot of infant mortality is what we call multifactorial, has a lot of causes, but smoking is probably one of the single most obvious causes that is clearly modifiable. What I would suggest as you continue your work is to focus on clear and simple goals. So I mentioned on the preconception side, even knowing that a lot of pregnancies are unintended, if a patient takes a medication each and every day, they merit preconception work and consultation. The other thing I would suggest regarding prenatal care, and this I think was a cornerstone of the New York experience while I was there, is the earlier the prenatal care in the pregnancy, if it occurs in the first trimester, the better. And New York put a payment system in place that encouraged 80% of all pregnancies receive prenatal care in the first trimester. If we could get to that and achieve that simple goal, I think you would see, as a result, a positive impact on a lot of the metrics that you're studying here right now. So that's my pitch, and I thank you for your time.
Thank you, Ed. Jeff?
Good morning. My name's Jeff Beal. I lead the Healthcare Collaborative of Greater Columbus. We're a public-private partnership. I get the privilege of working with leaders from healthcare, government, business, and the social sector of our community, really looking at how do we align our healthcare system to produce better outcomes. And so we do a lot of work ranging from helping people enroll into insurance all the way through aligning incentives. And I work for a community board of 23 leaders that's very diverse and very strategic. And to echo the previous comments, our community is very unique in that people are accessible in our community and there's a real spirit of collaboration. I spend my day working with competitors and they come in the room, and they really care about our community, and that's what keeps me motivated to do this work. One of the things I wanted to share with you today is maybe a framework to think about the delivery side. I understand that most of what impacts our health status is outside of the delivery system, but I spend my day inside the delivery system, so that's the way I'd like to share some of my comments. There are a couple of things going on right now that I think provide a great opportunity for this task force to consider. We have a lot going on around the Affordable Care Act. I refuse to call it Obamacare. And the Affordable Care Act is mainly what gets all the visibility is about helping people enroll in insurance. And that's very important, and I have some comments on that. Because insurance does reduce a huge barrier to access to care, especially for vulnerable populations. So we have a real opportunity with that. But what's not known widely about what's happening in healthcare transformation, some might call it a revolution because it's a quiet revolution, is the alignment of financial incentives. And in your packet behind, tab 2, there are a couple of visuals here around an innovation plan that I want to comment on. So let me back up and talk about what's going on with insurance and around removing that barrier to improve access to care. We have I think there was a map in your pre-read material. There are about 46,000 adults in Franklin County who are now eligible for Medicaid and don't have a regular source of health care. We know from working with a lot of the community groups that are helping to sign people up for insurance, it's taken about 3 times as much effort to sign people up for insurance than what was originally estimated. And what we're really learning is the real struggle of helping people prioritize health. In fragmented lives, there are a lot of other priorities, and the concept of insurance is foreign to a lot of populations in our community. So the opportunity there is to really optimize Medicaid enrollment in our region. And I like to remind people there's a lot of noise out there about the Affordable Care Act, and I'm not an advocate. I'm a neutral player in this politically. But the intent is to enroll 30 million people through different mechanisms by 2020, not by March 31st of this year. And that never gets reported. So we've got a multi-year journey here to figure how to reach vulnerable populations and pave the way for them to be able to better access care by removing some insurance barriers. On the aligning incentives, there's not a day that doesn't go by that I'm not in front of providers who tell me, why won't the system pay me for what you want me to do, or why I went into medicine? And this gets into this aligning financial incentives, and I'd like to draw your attention to this tab handout. Under Governor Kasich's leadership, his Office of Health Transformation spent a big part of last year bringing together leaders from hospital systems, from providers, from commercial Medicare and Medicaid health plans, and other stakeholder groups. And what's in front of you is a 5-year roadmap for how we can begin to align commercial Medicaid and Medicare payments to ultimately get at providing the right kind of incentives to produce health outcomes. What's happening in the delivery of care right now is we're moving away from a system that's transactional in nature, where more is better. Some call that fee-for-service, to a system that starts to reward providers for producing what healthcare is intended to do, to improve health. And that's not to say that providers don't want to do that. The payment systems are a big obstacle. So I'd be happy to dig into this in more detail. But there's really a big part of this plan that's around strengthening primary care that gets at these preventative measures to impact these chronic conditions that we're talking about. And then there's an episode care module that really gets into providing incentives for hospitals, specialists, and other healthcare providers to improve care coordination and continuity of care. What's really significant about this plan is that the largest commercial insurance companies in Ohio and all the Medicaid plans have already signed on to this. Think about that. We finally have all the major payers in the room talking about aligning payment incentives to encourage providers to focus on outcomes. What's missing, and this is an opportunity I want to close on, what's missing is we need large employers and local government to be sitting in front of their plans and say, let's make this a priority. That is the potential risk of this plan, is that there's not enough momentum from the people who ultimately pay a lot of the insurance bills, that being government and employers, to get behind this plan. And I think that's a very actionable thing this task force could consider in its recommendations. Thank you.
Thanks, Jeff. Mashika.
Good morning, everyone. My name is Dr. Mashika Williams-Roberts, and I serve as the Medical Director and Assistant Health Commissioner here at Columbus Public Health. And I'm very happy to be here with you this morning. It gives me a break from talking about the mumps, so thank you for that. I have really dedicated my career to public health and to preventive medicine. And so this concept of preconception health and how to reduce infant mortality is very near and dear to my heart. Here at Columbus Public Health, we offer a variety of services to help a woman have a healthy pregnancy. And at your last session, you had an excellent presentation on the life course analysis, the life course analogy. And I would say that the services we offer here follows that in many ways. Obviously, we have a family planning clinic where we help women decide when they want to get pregnant. We also have home visiting programs for those women once they get pregnant. We have a WIC program for the young babies once they're born to make sure they have access to healthy nutrition. From there, we offer an immunization program where we offer all shots that any child would need, as well as adults. And we also go into the school systems to make sure those children are healthy during the flu season. In addition to that, we have a sexual health program where we not only do outreach in the community about sexual health, safe sex, but also we provide services to individuals who come to our clinic to make sure if they do have an STD, we treat it so they don't spread it. We also have an alcohol and drug program for men and particularly women to make sure that if they are using, that we can help them stop using. In addition to that, we have a social work program that helps individuals get connected to care and services in our community that can improve their lives. We have a great partnership with one of the federally qualified health centers here in town, CNHC, where we connect individuals to primary care through a program here called the Bridge Clinic, where individuals who are seen and for our services, our specialty services, who need a medical home, we refer them to CNHC so they can get a medical home. And then we have our chronic disease prevention program, which helps individuals live healthy lives through active living, healthy food and nutrition, and community gardens. So there's a lot of work that we do here on a daily basis that helps a woman make sure that she is healthy before she becomes pregnant. And we continue that work with our community partners. We realize how valuable that is, but we also know there are a lot of barriers to women in our community for that preconception health. And that's something I think we're going to discuss further today, so I won't go any further, but I do appreciate being here this morning, so thank you.
Thank you. So, Mashika, I actually want to start with that next question is, how do we take the high number of women who Jeff already talked about aren't accessing and don't know about insurance, don't have a culture of insurance, don't have a culture of a regular medical home, which you've also mentioned. The people who aren't getting the preconception care, we have all this knowledge now about what we need to do. Why doesn't that happen? And maybe we can go in reverse order and sort of mention that.
I think a lot of it has to do with education. I think there are many women, particularly in our community, who don't understand what preconception or well woman care is. I tell a story I was telling Julie the other day. The number of women who come into our sexual health clinic for an STD check, and I ask them, when's the last time you had a pap smear, or when's the last time you had an annual exam? And their response is, well, I was here a year ago. Well, you were at the STD clinic and you saw a doctor, but that doctor didn't do a full exam on you. They did a very focused exam. So there's this misconception that if I see a doctor, if I see a provider, I've had medical attention. And that's, as we all know, that's not accurate. So I think that we need to do a better job of educating our women, and we need to start at a young age, the importance of having a primary care home, the importance of having a relationship with a provider that can look after your health and all aspects of your health, not just one particular aspect of your health. So I think there's a huge misconception out there in our community about the value of a medical home.
I would build off of that and add that improving care coordination and linkage between the delivery system and community services is going to be vital to this. There's a tendency to think about healthcare being provider-centric, and what we're trying to do is change the system to be more person-centric. And a lot of that is meeting people where they're at, and through education begin to build those linkages into the appropriate place of care. And that's an easy thing to say. The infrastructure and the incentives aren't there to do it, but we don't have to invent anything to figure it out. We actually know how to do it. So you'll get tired of hearing me say this. I keep coming back to incentives, incentives, incentives. We really need to provide a way to shift the financing system to really support a focus on person-centered care that produces the desired outcomes.
Go ahead.
I think a lot of it goes back to what I try to teach medical students, in that if you want to have good outcomes, you have to make it easy for your patients to do the right thing. And just to review some of the recent history, last 2 or 3 years, Ohio only recently embraced the concept of presumptive eligibility for pregnant women in Medicaid. So it used to be as recently as 2 years ago, and this is something New York had done 15, 20 years ago. It used to be that if you were pregnant and you were presenting for care, the burden of proof was on you to prove that you're eligible for insurance. Now we're in a situation where you're going to get seen and you're going to get insurance while the paperwork grinds its way through the system, so that we don't, by a systematic process, interject a 2 or 3 month gap in care. Remember what I was saying before about the importance of early prenatal care. I still have to wonder what barriers linger as far as accessing care. The other thing, and I know we're being politically neutral here, and I'll remain that way, no matter where you stand on immigration reform, we can't ignore the issues faced by undocumented women and their babies. And I look at it purely, because it's apolitical, as an economic proposition. There's a huge body of literature from neutral parties like the Institute of Medicine that makes a case that for every dollar prenatal care that you spend, you save as much as $3.38 down the road. And there's, again, a good body of literature to say women who present to the hospital with no prenatal care run up hospital bills, including their newborn, that are at least double that of those that get regular prenatal care. So I think that's an aspect that needs to be in the solution. The other, I think, for any society is it's good to have an emphasis on values, but really a good barometer of what you value is what you spend your money on. So while it's expensive and somewhat debatable, the education that we're talking about needs to start with the mass media. Again, I'll point to New York with their I'm Ready campaign for pregnancy and their absolutely brutal anti-smoking campaign. And for any of you that have seen it and the images that they project as far as people that have physical deformities from smoking, it's hard to watch, but it works. And embracing some sort of mass media campaign to reach women that don't necessarily access the traditional means, I think is something that needs to be considered as well.
So I'm going to persist in my questions because I have a lot of questions, but I want to start and make sure the task force has any. Yes, please.
How does this work, Dr. Long? Is this on? Okay. Good morning. Dr. Funai, I had a question that kind of piggybacks on what you were just talking about as far as the mass media is concerned. I'm the mother of a 9-month-old, and thank you. I cannot tell you, pregnancy was an interesting experience in that it's very obvious that it's happening, and everyone feels that they can comment on it.
Yes.
And the amount of information that comes at you is amazing. I remember being someplace, and in 1 hour, I was told I was having a boy because I was carrying a certain way. Then I was having a girl because I was carrying the same way. And babies should sleep on their back. Babies should sleep on their stomach. You can smoke. You can drink. I mean, you know, just tons of information that was all different. And so I wanted you to talk a little bit more about how to get out not only information to a lot of people, but getting out the correct information to a lot of people.
A couple of comments. Number one, there are certainly reliable sources out there, such as WebMD. I think all the health systems in town have FAQ pages around pregnancy that are very reliable. But again, that presumes that people are going to have access to computers, that sort of thing. Again, what I've seen, going back to the patient-centered medical home model, if we align incentives, that is physician incentives, patient incentives, and build a prenatal care structure that has the educational components around it, pregnancy is almost a time to get an associate's degree in being pregnant and childcare. And women are highly motivated to get high-quality information during that time. But not all care settings have educators, social workers, resources to provide that sort of education, but I find women to be a sponge. And if we can come up with a systematic way to provide that information to push it out with pregnancy, it's not only going to have pregnancy and infant mortality effects, I think it's going to have lifelong health effects, because it's probably the time in a woman's life where she's most engaged with the healthcare system.
Yes.
Good morning. Did I do this right? No? Yes? Okay. Good morning. So when we talk about creating this healthy community for moms as the carriers of our young babies, what is still kind of missing for me, and Julie and I had this conversation the other day as well, is including fathers. We rarely talk about the impact that fathers have on the lives of these women, even during family planning stages. Can you talk a little bit more about perhaps some models that you've used in other states or maybe in your work where you see that including fathers in the pre-planning along with the pregnancy stages really help mothers be able to sustain the pregnancy?
Can't necessarily speak to a gender-specific program. I think, again, going back to the idea of pregnancy as a time of education, a lot of the actual intrapartum outcome, that is the labor and delivery, the outcome vaginal birth versus cesarean, is very much tied to encouraging having a support person, a key person, whether it be the father or not. There's, again, a good body of literature that cesarean section rates are lower, pain experienced is significantly lower, and again, to have that emotional support throughout the course of pregnancy. So there are some models of care that would include that significant other or support person from the very beginning, and also include them in the educational process. What we didn't touch on, too, is childbirth education around labor and delivery and the accessibility of that in the region. Again, is another way to engage preparing for the actual birth, to get people involved and supporting. So that's a modality that we can use and probably expand.
Answer your question. I do believe in New York, in the North Manhattan area, they do have a fatherhood university. It's I don't know how long it is, but it's a program designed for expecting fathers to help them support the expecting mother and to be there for the baby. I don't know a lot of information about it, but I do know that that is something that they are trying there. So I don't know if they have outcome data yet.
Yeah, please.
For a long time. As we benchmark Columbus with other cities like New York, do we have enough? Are there enough slots? Are there enough access points? Or is it folks just knowledgeable about needing to get it? Or is it both?
Do you guys want to go ahead?
On the primary care side, our best estimate is we probably need somewhere in the range of 30 to 50 more FTEs on primary care in vulnerable neighborhoods. But because of the fragmentation in care, Dave, I think there's a lot of wasted capacity in our system as well. And I think that gets overlooked, that because there's been a traditional silo approach to delivering care, we do end up with a lot of imbalances between supply and demand.
Standpoint, because a lot of the healthcare systems have access points. I don't think they're very well coordinated. I don't know if we've done an inventory and say, here, let's kind of rationalize what we have this way.
That's right.
So I've often wondered, should we just provide more, or is it a lack of knowledge about how to access it, or should we reallocate what it is that we have, because resources are limited, and we ought to use the ones that we have as efficiently as we can.
That's right.
And timeliness is a missed opportunity. There are times where wait times can extend up to 4 weeks to get an appointment across the city.
So is that part of the plan, is to do the inventory and assess what it is we have?
So we do have a type of inventory that's done now by Pregnancy Care Connection. That's an annual wait time call. It happens in January of every month. It's released in April. It's a survey done through the Council on Healthy Mothers and Babies. And that survey shows that low-income women often have 3 to 4 week waits in various things. But that's not true on the commercial side. We have not surveyed on the commercial side.
I think you'd find from the leaders of the healthcare system, we've kind of talked about it among ourselves at our meetings, Steve's been in those, that I think we're open to finding a way to coordinate that so we can use what we have as efficiently as we possibly can.
That's exciting.
So don't hesitate to ask on that.
Teresa?
So, good morning. So, we're getting into some of, and we don't have to get too deep, but I think, David, you're asking a really important question about capacity, and really about all of these, about primary care, but about prenatal care. And my understanding is that there are, and I think Dr. Funai was saying we really need to dig in and understand some of the barriers that even currently exist. One, for instance, could be that you have to have written documentation from a provider that you're pregnant before you can get into prenatal care. So where can you go to get a low-cost or free pregnancy test? Of course, someone was just challenging me about that because we do that here at Columbus Public Health, but we make it available from 10 to 2. So how available is that, really? And now I'm outing ourselves, but I would challenge any of us in the health system to think about how really available, what are our copays, what are the what are we talking about, the eligibility? Does that really work? Say it again? The presumptive eligibility, does it really work, or is that a barrier? Is it slowing us all down in getting women into that early care? So I would like to think that these are all things that when we dig in and look at real barriers that add either capacity or the opportunity to serve, that we could really think about some of those issues. So thanks for bringing that up. There is no doubt in my mind that our health systems are committed to working on these issues. So I have a question for the panel, or was there someone who also had their hand up? Somebody else did.
So these are good ideas, and we're anxious to get a few more. It's time for everybody to go to work. It looks like the coffee's starting to work, and we're all waking up here a little bit. So we seem to work well in groups. We're going to do that again this morning. We're going to ask everyone to continue with some of this discussion. Consider these options that we've talked about, develop potential recommendations for improving preconception health, as we've talked about. So we're going to ask you to meet in the groups that you're in. Consider perspectives from, as we've heard, employer, educator, healthcare provider, insurance companies, as well as regulator and policymakers. We know there is some controversy on the message, some controversy on where the message can be delivered. What we know is the message needs to get delivered and needs to be communicated. That's a given. So we've provided a preconception health resource guide to help inform your discussions in your groups. It includes local data on key preconception health indicators in our community and insights about potential interventions from other communities. They were passed out. Everybody should have them. So it's about 9 o'clock. In about 15 minutes, or 9:15, we're going to get you back together and ask you to report out. Some members of the panel are going to move about and discuss with you and your groups and assist you in your deliberations. So, as well, members of the public who have joined us this morning, we're delighted you're here. You also have the same resource guides. We would ask you to meet with your neighbors there that you're sitting with, have the same conversations, and we're anxious to gather your responses when you've completed as well. So if you could jot them down on some of the materials that you have, that would be helpful. 9:15. So we're going to spend a few minutes hearing some perspectives of what's been discussed. We're going to ask each table to offer a brief summary of your discussion, and we're going to record some of these notes. And why don't we'll just maybe start right up here in the front. Mark?
And what can employers do? There was a suggestion need to include small businesses that employ disproportionately immigrant workers. Under educators, add a health component to the Columbus Kids Ready, Set, Learn. Also explore with school districts what can be done more in terms of prevention programs and educating young people about the choices they have, and improving cultural competency among the people who do the outreach. What can health providers do? More care by midwives and other mid-level professionals. The message was it doesn't always have to be a physician. And improving care coordination. Under insurance, more mid-level providers and policymakers. There was praise for the presumptive eligibility as being a help, an acknowledgement that there's still waiting lists, but there still needs to be more proactivity with teenagers before they get pregnant. And the county, we had a county commissioner with us, the county has supported programs for young people in a variety of settings.
Great. Thanks, Mark. And Dr. Long, you were just finishing up our last conversation, so we'll throw it back to you there.
Wow, you're calling me out. We had a lot of ideas. So what can employers do? Well, we felt it was of mutual benefit to really focus on the women's health, as well as obviously everyone's health. So to really support women meaningfully, and both employers and really across the board, to really move forward an Every Woman, Every Time campaign that employers could be a part of, but obviously physicians are a part of that Every Woman, Every Time campaign, that these kinds of issues, and even though they're hard, and we may need to coach all of our providers to address daunting subjects, but these need to be addressed. And if they're supported with multiple channels of information, whether that's through employers, through a public campaign, as well as through providers. We had a good conversation about insurers and all of us wanting to pay for quality. So again, it's saluting what's starting, but really trying to, again, see that those incentives are aligned for improving health or protecting the good health of women. We then had, as far as policy, we felt that clearly, and we again salute the governor for putting a 60-cent per pack tax on tobacco, but this group said, let's go further, let's make it $1, led by Michael Fiorelli saying that. But with that, we really felt it was important to, the funds we understand that currently are in the proposal really are around income tax reduction across the state, but to use this additional 40 cents to, again, reduce barriers to care meaningfully and to move forward a campaign potentially brutally honest about the health of women and the connection to smoking with that. So use those funds. We listened carefully to what Dr. Finai said. And we also felt through all of these that it was really important to listen to the voices of the women as we would start to move forward on any of these kinds of efforts, both women in the workforce, women who are not in the workforce, the kinds of stresses that they're feeling, and to build those voices into the campaigns and to what we do. Oh, I'm sorry. Oh, yeah, and of course, when we talked about the daunting subjects, thanks, we meant things like talking meaningfully about domestic violence, about substance abuse, about smoking, that these are really challenging for all of us to address. But in fact, if we do not, we'll be missing some of the key drivers, just like we said, of the issues that cause infant mortality.
Great, thank you. So back up over here. Karen, you can tell the governor we're appreciating his tobacco tax increase, and we're raising it even more for him before this one gets approved. So where did you guys come out?
We spend most of the time talking about prenatal care, access, and the overall capacity of what it is that we have. And I think we don't know how much capacity we have, and we need to find that out. Where that is, hours it's available, before we start throwing more resources at that topic, because I know just from a high health standpoint, we've got capacity we're not using. And if we could get that in the right place at the right time, that would be helpful, and I would think every other health system in town, as well as some doctor's offices and FQHCs and clinics, might also have some inventory that we should throw into the pool. Look at that pool as a true community resource and allocate it the best way possible before we start throwing more resources at it. And there are several of us that have been at this for a long time, and we've tried to solve this problem with the clinical model of providing additional availability to prenatal care and not see the needle move much. Where it's focused, we do, but from a broad community standpoint that we don't. And we thought that was an important thing to do. And once you understand that, then you can work on the problems of what employers should do, what schools should do, what churches could do to knock down the barriers for access to prenatal care. So we thought in inventory was probably something that we should do soon. Group, did I cover it? Okay.
So obviously an inventory is a good idea, as well as an inventory on what the previous efforts had achieved, or not achieved for that matter, so that we're not kind of reinventing the wheel, if you will. So, and then the last table back here, who's reporting out?
Well, we took to heart and listened to the panel as studious as we could, and the themes that we took back to our conversation really focused on being person-centric, be where the women and girls are, increase access points, and then incentivize. And how that goes into each of these categories based on our dialogue was looking at when employers can increase the ability to mandate or get close to that mandate with an annual exam, and that is highly dependent on the size of the employer. So for larger employers, is there the ability to do on-site clinics? For mid-sized employers, is there incentives for care? Is there collaboration that can be done? We're talking even nonprofits and other private and public sector, and then we got to small and nonprofit discussion, and that was a whole nother complex issue to address. But where can you go where the employers or where the employees are in their daily routine? With educators, it was how can we create from that high-risk age category of 13 to 21. We know the importance of taking care of babies and infants, but in looking at preconception and knowing that we're going to be talking about teen pregnancy, there's a gap in health care for 13 to 21-year-old women and girls. So what is going on in that age group and that demographic if they are not required to have a health exam entering middle school and high school? So is there an opportunity to do on-site health exams? And we've had the opportunity to offer a name of ears to ovaries, both in the at a 7th and 8th grade access point, and having the conversation and normalizing health care. Normalizing healthcare, to include and go beyond just what does it mean to exercise and to eat, but there's what's going on inside your body that you may not always see. And then again in 8th grade, and then also looking at a post-secondary health exam requirement to enter higher education, because that is not a requirement, and yet you're going into an entire world where you don't have adult supervision, but have you normalized healthcare for yourself? The next piece with healthcare providers is obviously now this underscores the system, that an infrastructure that can support those ideas that we've offered, but increasing access points. So if we do need more full-time employers, the 30 to 40 that Mr. Beal mentioned, but are they at the right locations? Are they at the employers? Are they in the neighborhoods? Are they where they need to be? Insurers, that's a category that I choose not to spend time in because I am not knowledgeable, as others have offered suggestions, but are there ways to incentivize their work with employers and the healthcare providers? And then lastly, looking back again at a lot of this is what we focused on was that preconception age, 13 to 21. Where can there be policy change, and where can we advocate to create requirements for healthcare providers, for insurers, to help underscore the importance of lifelong healthcare really starts to be put in place age 13 to 21. Anything I need to miss? Okay.
Thank you. So sounds like the employer piece can be a big part of the puzzle. We were talking back here, Teresa, what was the percentage? Was it 45%?
45% of, we were talking about smoking?
Right. Pregnant mothers.
Right. There is data, and actually I was referring to Karen Hughes to the newer report coming out that looked at the PRAMS data across the state of Ohio. And in that, the state of Ohio has looked at all kinds of issues, but related to age and to income, et cetera, and then to risk factors connected to prematurity and infant mortality. And if you look at the income connection to smoking, the lower the income, and again, it plays out whether you're pregnant or not, but it goes way up. And I believe the percentage, I don't have it here, but I think it was about 45% of lower income women are smoking while they're pregnant. Is that good? She's nodding.
So that is certainly an education piece that employers could play a role in. As most employers move to health care discounts for non-smokers, that's an important piece. So all good stuff. We've gathered all this information. It'll be part of our recommendations. And now I'm happy to recommend about a 10-minute break for everybody. And we'll get together again soon.
We want to collect their papers.
Oh, yeah, and around the sides, if you guys have
your
written up
write-ups.
some recommendations, we're going to collect them.
Please, thank you. From the tables and around the room, that would be very helpful. Thank you all. We were just having some sidebar conversations when we think about these recommendations and we think about the systems that we have in place. Many of them we've sort of outlined here. It's figuring out the folks that are impacted that are outside of these systems. So the teens and the young women who are not in school, because we still have that challenge that we're working through, and then and our unemployment rate is better, but for certain populations it's still not good. So we talk about employer solutions. There are people who are unemployed that are part of this. So part of our recommendations when we talk about systems is how do we reach people that are outside of our systems but may be a big part of the impact that we're trying to bring. So we'll keep that in mind for the record. So next, what we'd like to do on our agenda is move to a wonderful discussion. We're very, very fortunate to have with us Sarah Brown to discuss some very important issues. Nice segue from the conversation we just had. Sarah is the CEO for the National Campaign to Prevent Teen and Unplanned Pregnancies. A lot of times we hear this title and we stop at teen pregnancies, but I think you'll hear from Sarah how important that whole notion of unplanned pregnancies is to this conversation. Before helping to establish the campaign in 1996, Sarah was a senior study director at the Institute of Medicine, where she directed numerous studies in the broad field of maternal and child health. Her last major report there resulted in the landmark book, The Best Intentions, Unintended Pregnancy and the Well-Being of Children and Families. Still a great read and a wealth of information. She holds an undergraduate degree from Stanford University and a master's in public health from the University of North Carolina. I didn't tell you last night, that's where I grew up, North Carolina. Yes. So please join me in welcoming Sarah Brown. Sarah?
Well, thank you for inviting me here today. I always thank people in particular for getting me out of Washington, D.C. That's always a unique pleasure. So unfortunately, I have to leave very soon after talking, but even the last few hours have been wonderful. The PowerPoint that I'm using is in your book, so no need to scribble anything down or whatever. I hope you can refer back to it as needed. What I'm going to do very quickly today, I hope, is talk not at all really about the national campaign, except to orient you to it, but to talk about the link between infant mortality and teen and unplanned pregnancy. And in particular, I want to talk about things that can be done and what you all can recommend when you come to that point in your deliberations. The most important thing I want to ask, though, is that you interrupt me with questions. I will talk until the cows come home, until someone literally removes me from here with the hook. So please, just anybody, just say, wait, hold on, I don't get it, let's go over this again. I mean that sincerely. The organization I represent is focused on improving child and family well-being, as everybody in this room is focused. People come at that many ways. They work on school reform, they work on earned income tax credits, they work on WIC, lots of things. Our organization's focus is to support families, children, economic well-being by reducing teen pregnancy and unplanned pregnancy. It's not the only way to do it, it's what we do, and we think it is an underappreciated way to go about achieving these larger goals of overall family structure improvement, economic competitiveness, educational attainment, and so forth. We are a small group, but we do a lot of things, and we pride ourselves on being bipartisan, research-based, increasingly media-based, and working with unusual partners. We don't work with the usual list of suspects. Just for example, one of the groups we work with the closest is MTV in their franchise series, 16 and Pregnant and Teen Mom. Unusual partners. I want to begin by congratulating you here in this room for even considering a connection between teen and unplanned pregnancy and infant mortality. Few people do, in fact most don't, so you can congratulate each other, shake each other's hands, pat yourself on the back, well done. Many people, when they even see the words teen pregnancy, or even the word pregnancy, they start getting kind of nervous. It's like, uh-oh, where's this going? Are they going to talk about like condoms in 5th grade? Ugh. And I'm so delighted that you're willing to see this whole area in the larger context. Teen pregnancy and unplanned pregnancy, especially unwanted pregnancy, and we'll get to that in a minute, are indeed linked to preterm delivery, low birth weight, and many of the risk factors that lie behind infant mortality. So again, congratulations for seeing the connection. Now first, a little bit of word about the words. Everybody knows what teen pregnancy is because it's based on age. If the mother is 19 or less, that's a teen pregnancy. It's crystal clear. We get that day off of a birth certificate. Was this a birth to a teen mother or not? Unplanned, often called unintended pregnancy, is not that easily tracked and seen. And it's one of the reasons that we have less data sometimes in this area. Because in demography land, unplanned includes, in fact, two different things. A mother who reports that she became pregnant a little bit sooner than she wanted to. It's a mistimed pregnancy. Sometimes the mother will say, I didn't want to be pregnant at all, now or ever. Big time unwanted pregnancy. And those are both included in this more general term of unplanned. So it's sort of subjective in some way. kind of self-report, and it makes it a little harder to kind of nail it. Where is it? Is it getting better? Is it getting worse? Because you don't just check the birth certificate and look at an age. Even so, there is a clear link between both teen pregnancy and infant mortality. You can read this, I won't go through in detail. But the key concept is that the infant mortality rate for babies born to teen mothers is indeed higher than for women who are 20 and older. Younger teen moms are at greater risk, a 14-year-old, for example, but there are very, very few of those. They're always deeply concerning, but there are not a lot of them. Unplanned pregnancy, again, there's a link. Unplanned pregnancy, especially unwanted pregnancy, as I mentioned a minute ago, is associated with higher levels of preterm birth and low birth weight. And the pathway here that we often follow is through common risk factors, particularly in this area of unwanted, unplanned pregnancy. There are a lot of risk factors that people look at when they try and learn about infant mortality. I'm sure you've been down this. I'm going to talk a little bit about the ones that are underlined. Low birth weight, preterm delivery, and intrauterine growth retardation. These are major predictors of infant mortality. You know that. If a baby's very little, very early, very ill, that baby is at high risk. There are biological risk factors, certainly very young teens, as I mentioned just a minute ago, but also old ladies too. Reduced participation in preconception care can increase the risk, or maybe failure to be offered preconception care. Late entry into prenatal care has already been mentioned several times. Riskier behavior during pregnancy, also mentioned several times. Short interpregnancy interval, environmental risks and stresses, and I include in those a wide range of socio-demographic stresses. Poverty, we increasingly understand, is very bad for your health. Now, more specifically, just on those three again very quickly, births were 2/3 more likely to be low birth weight if they followed an unwanted pregnancy compared to a planned wanted pregnancy. In 2010, 14% of teen births were preterm and 10% were low birth weight, again linking some of these issues. We can go into this, we could do this till 2 o'clock in the afternoon. I'm just trying to give you just a few highlights. Prenatal care, 19% of women with an unplanned pregnancy do not begin prenatal care in the first trimester of pregnancy. If you are not planning to become pregnant, you are less attentive to, gee, I might be pregnant. You're not thinking, I missed my period, I'm pregnant, I'll go get prenatal care. Not surprising. 43% of teen mothers, 43, do not begin prenatal care in the first trimester of pregnancy. So you see, all these things are linked. It's age, prenatal care, planned, unplanned. It's a very complex mix. But I think your kind of intuitive understanding here, in fact, is correct. Planned, wanted pregnancies to women who are neither too young nor too old, in fact, carry a lower risk of low birth weight, preterm delivery, compromised neonatal period, and infant death. And I just mentioned the interpregnancy interval. We're going to get to some good stuff soon. So I just want to make clear this logic chain. When someone says, wait, you're an infant mortality task force and you're talking about teen pregnancy or what? I don't get that. What we say is that if we have fewer pregnant women in Columbus who are teens and or who became pregnant unintentionally, especially unwanted, we will, by definition, have fewer pregnant women with major risk factors for infant mortality. And because we will have fewer people in this pool of higher risk women, we will have a lower infant mortality profile. Does that make sense? I think you all understand this, but I just want to make absolutely sure, because you're going to be asked, why are you even looking at this dimension of pregnancy planning, teen pregnancy, and so forth? Here is my favorite takeaway. I drew this on a napkin, literally. You know, they talk about people sitting in restaurants drawing stuff on napkins. This is what happened. I was sitting in a meeting on Capitol Hill with some Senate aides trying to explain just sort of what we went through, how pregnancy planning and prevention kind of affects things, including not just infant mortality, but child well-being and so forth. And I wasn't making any progress. That often happens to me when I'm on the Hill, so it's a very familiar experience. It's like they kind of look at me, and I said, okay, now let's just pretend, no offense to anybody, we're going to do this like 6th grade. And I sort of drew this out. Here's the thought. Like sort of as my kids would call it, not a conceptual overview, they call it a conceptual overhang. Here's the thought. Everybody in this room, I think, agrees that we want to reduce infant mortality. Like, I'm just going to stipulate that. But if you think about it, if you think about past efforts even in Columbus, I know you were at this in the early 90s. If you think about it, most of what is done nationwide to reduce infant mortality is on the right side of that dotted line. There's a lot during pregnancy of prenatal care and all education and supports, and we certainly pay a lot of attention to trying to get people in good hospital settings for the best care they can get. And we absolutely think about guidance for infancy, safe sleeping, all the things we need to teach mothers, all that stuff. Those are all terrific. They're very important. I'm not in any way suggesting they're not probably the most important. What I want to ask you today is to look at things on the left side of the dotted line, and incidentally, that bright red star is conception. Most of what we do occurs after conception. And yet we know that a lot of what we can do to improve matters occurs before conception. And that's what I want to concentrate on. Again, it's not instead of, it's in addition to all the things that are done on the right. It's going upstream. It's going sort of before the fact. It's, upstream, getting it right from the outset. Once a pregnancy is in place and those risk factors are all there and we have all the problems that you all understand better than I do, it is harder to intervene than to intervene on the left side of the dotted line. Make sense? Okay, we have to have a question now because I've already talked for 10 minutes without taking a breath. Please. Oh boy. I appreciate that.
Your next slide, which is the good news slide, what do you attribute the drop?
So there is great news on teen pregnancy and childbearing nationwide. The rate of teen birth in the U.S. is down 52% from its high water mark in 1991. Pregnancy data lagged behind, but up to about 2008, 2009, it's down 44% nationwide. And I'll talk a bit about Ohio. I think this is one of the greatest good news stories that nobody knows about. There are only 2 things that can drive a pregnancy rate up or down among teens or anybody else. It's some combination on the left side of the dotted line of whether people do or do not have sex. People who don't have sex are not going to be contributing to the teen pregnancy and birth rate. And then for those people who do have sex, using or not using good contraception. The people who use really, really, really good contraception generally don't get pregnant, so they don't contribute to the teen birth rate or the unplanned pregnancy rate. The people who don't use good contraception or use it only once in a while tend to get pregnant. We get to the red star, and then we're off and running on these rates. So the way to say it simply is the teen birth rate has gone down through a combination of less sex and more contraception. It varies by community, but for example, we know from national data that fewer teen boys report now having had sex in high school than they did a number of years ago. I'm not going to look at any men and saying that because they all say that's not true. And I say, yes, it is. And I think the reason is we've seen an increase in condom use, and I think that in turn relates to all the education about HIV and STDs. It's caught the attention of boys, not just girls. But in addition, there has been more use of contraception by those teens who are having sex. Less sex and more contraception. People argue about the proportions, whether it's 50-50, 60-40. It's predominantly more contraception, but it is some less sex. The more important and puzzling question is, well, okay, let's pretend it's 50-50. It isn't, but let's just say, why are young people being more careful? And that is where the science gets really, really weak. It's a combination of changing social norms. It's a combination of state policies and advocacy. It's a combination of more parents are talking to their young people about sex, love, and relationships. It's many, many, many things. And what I'll often say to a community is, I don't know what you all are doing, but keep doing it, because these teen birth rates are falling through the floor. They've accelerated in the last few years. It was going down, and now we're really on a steep decline. One of the reasons, I think, and then I will keep going, one of the reasons is that one of the principal risk factors for teen pregnancy is being the daughter of a teen mother. Just as was said earlier, one of the principal risk factors for preterm delivery is having had a previous preterm delivery. And as we get the teen pregnancy and birth rate down, we in fact are having fewer teen mothers. We are reducing the risk pool back to risk, and fewer teen mothers beget fewer teen mothers. It has somewhat of a self-perpetuating dynamic. There's a lot more going on, but you get to a tipping point. For those of you who remember Malcolm Gladwell's book on the tipping point, things are going down, and then the internal dynamic becomes self-reinforcing, and it continues down. Great question. Even so, 3 in 10 girls get pregnant at least once in this country before their 20th birthday. A number of them have a second pregnancy and a third. About 20% repeat pregnancies before 20th birthday. The U.S. has the highest rate of teen pregnancy and birth in the entire industrialized world, even with the 52% decline. What country has the lowest rate of teen pregnancies and birth in the world? Anybody know? It's my favorite question. South Korea. Just FYI, just saying. In the U.S., about 722,000 girls get pregnant every year. 722. Now in Ohio, as you know, you still have a significant teen pregnancy problem. About 34 teens, Donna, enough to fill maybe one kindergarten classroom, give birth every day in this state. 28% of all teen births are to teens 17 and younger. This is important. The vast majority of teen pregnancies and births are to 18 and 19-year-olds. We're always thinking it's all 15-year-olds, 16-year-olds. This is a phenomenon largely of 18 and 19-year-olds. These are not minors. It highlights, for example, the importance of looking at community colleges and other settings like that to reduce the teen birth rate, in addition to other issues. 15% of infant deaths were to babies of teen mothers 15 to 19 in the most recent year we have data for in Ohio. 35% of infant deaths were to moms 20 to 24 years old. You have your Ohio data. I'm not going to go through this a lot. And you know about Franklin County. More than 2,400 teen girls get pregnant each year in this county, and more than 1,500 teen girls have given birth. More than 9,800 births resulting from an unplanned pregnancy have been noted in this county, 2010 data. Okay, we are now going to get to things you can do, or I guess more precisely, things you can recommend. As my kids would say, MGTTP. Do you know what that means? That means Mom, get to the point. After all, it's like, enough, okay? Get to the point. There are a lot of things you all can do, and what I'm going to talk about is not so much what you can do to reduce overall infant mortality, although I'm happy to do that. It's more what you can do overall to reduce teen pregnancy and unplanned pregnancy, which is what I was asked to talk about. But I'm happy here and there to intersperse it with things that are a little bit broader. I think in order to reduce teen and unplanned pregnancy, you have to tell the truth, you have to get to the point, and you have to explain the logic chain that I went through about really why we're doing this. It means that in order to include these two issues of teen and unplanned pregnancy in your efforts, and in order to encourage good interpregnancy intervals and the use of birth control, you have to say why. You have to explain this logic chain, or however you would put it together. Most people don't think about this stuff all the time, and they, as I mentioned at the outset, will not automatically and intuitively see why working in this area would help. They will become nervous because, again, no matter what you say, it's condoms in a fishbowl in the 5th grade, which of course it isn't. But if you don't take the time to say, here's why this is one part of the answer, you will lose people because of the long history of unfortunate controversy on this. So what that means is you have to do something like this, or something like this, or something that works for you, that explain, on this one you would say, here's what we're doing during the pregnancy interval. Here's what we're doing about neonatal intensive care units. Here's what we're doing about safe sex. We'll also need to work on this left side of the line. You don't have to have the dotted line or the red star, FYI. But that's what I mean. You're going to have to explain the link. I was very heartened by the discussion of preconception health care a minute ago. Fantastic panel. We have to explain that by definition you can't do preconception care if you're already pregnant. Very few people say that. The CDC, you have to get to page 5 of their preconception guide before they even say family planning clinics are often the place where you see women and where you can do preconception care. How is it that they are seeking pregnancy but not pregnant? It's probably because they're using contraception. You have to get that interval of a month, 2 months, 6 months, a year to screen the women, get the risk factors that you can affect under control. Preconception care requires family planning. It's like that's the untold sort of basic part of it. You can't do preconception care on a pregnant woman, right? Everybody hanging in there? Okay, I just, I never know where I'm losing people. Just to drive home this point one more time about explaining this, if anybody here, and I know no one would do this because I've met a number of you already, if anybody just stood up and said, we want to reduce infant mortality in Columbus, and here's what we're going to do. We are tripling our commitment to family planning. Even if the headline said, reduce infant mortality Columbus, everybody would head for the exits. So you have to put this in the proper framework, or you lose people. That's my experience. In order to reduce teen pregnancy and unplanned pregnancy, you have to commit to contraception. I understand some people say it's controversial, but ponder this. 99% of American women have used contraception at one point in their life. What's controversial is the public expression of it. It is not the use of it. And we have to understand that there's a difference. And I often think of we have it, never mind, it's too long. Contraception is not abortion. We have very good data that it does not encourage early or non-marital sexual activity. Contraception is far less risky than pregnancy, labor, and delivery, if people want to talk about risks. It is widely used and saves money. Depending on the Supreme Court hearing, it will be widely covered by the Affordable Care Act. It already is, but it will be even better, more covered. But we have to pony up here, have to man up and woman up. If you want to reduce teen and unplanned pregnancy, one of the things, not the only thing, one of the things you have to do is be able to talk about and be comfortable with contraception. In that context, I want to leave with you something that we developed very recently, and I hope you can get it into the materials perhaps for your next meeting. It's really dorky and wonky, and it's like 10 pages, or no, it's not that bad, it's 5 pages. It's called Getting the Facts Straight on the Benefits of Birth Control in America. And what it talks about is how birth control reduces abortion, how birth control advances women's education and employment, how birth control advances improved maternal and child health, and infant mortality is squarely in this section. It talks about how birth control improves family structure and well-being, and its benefits to society, including reduced public sector costs. Because I think it's on those types of platforms that we properly discuss this particular intervention. Assuming now that you have committed to contraception and your recommendations in some well-framed and appropriate way, it is very important to understand that it is a new day in contraception as compared to where you all were, for example, in 1992, the last time you went at this seriously. Not all contraception is the same, not all of it is equally effective, and so on and so forth. And the most important thing in this field that has happened, I think, in the last 15 to 20 years is a series of reports published last year, and we can send them to you, from the so-called Choice Project in St. Louis. The Choice Project in St. Louis centered on a very simple idea. We are going to offer women, teens, women of any reproductive age, any contraceptive method they want for free. We are going to begin the counseling by saying, here are the most effective methods, and we suggest, as in all medicine, that we use the most effective methods, and if you don't want one of those or can't, whatever, we'll use another one. 75% of the women in this study chose one of the two new IUDs, intrauterine devices, and the balance chose the subdermal implant called Nexplanon. Teens, incidentally, more than older women, chose the implant. 86% of the women who chose the LARC were using it 1 year later. That is unprecedented in contraception land. The problem with oral contraceptives as a contraceptive sort of first line of defense is people don't stay on it. They break up with their boyfriend and throw them in the trash. They miss pills. They share pills with their best friend. They lose pills. Teens and pills and young adult women and pills don't go very well. I'm not going to ask for a show of hands, but I bet many of the people in this room are asked to take a pill every day for something. Hypertension, other things. Even all of us have trouble taking pills every day. It's very hard to do. And the notion of taking particularly a high-risk teen or young woman in a sort of chaotic life stage and saying, here, take this, see you in a year, the continuation rate is well under 50%, and for many groups it's under 25%. These methods are extraordinary. They reduce the abortion rate in St. Louis enormously. They essentially shut down the unintended pregnancy rate among these women, and they decrease the teen pregnancy rate a huge amount. I have data on this, but the teen birth rate went down 68% in a year. I generally don't think technology solves things in America. We always think we've got this new app and that's going to take care of weight loss or whatever it is. These new developments in contraception are literally changing the face of family planning in America. And one way you can make a huge difference in Columbus, not the only thing, we've already talked about all the things on the right side of the dotted line, but to the extent you want to work on the left side of the line, and you understand that the only people getting pregnant are the ones who are not using contraception all the time and are not using really good contraception, right? That top thing. But second thing, I'm saying, you see, they have sex. Some use contraception, especially if they're using an IUD or whatever, they're not going to get pregnant. We need to get that group that's in the non-inconsistent use or use of poor methods. That is the way in this side of the dotted line to reduce pregnancy. It's not the only way, but it is a critically important way. And I would be remiss if I didn't just tell you the truth. This is a major new development nationwide in helping women plan pregnancies. And just to be clear, these methods act a long time, which is good, but they don't have to be used a long time. So people say, wait, I don't want something put in me that I won't get pregnant for 10 years. Correct, very few people do. It could be removed 2 weeks later. It's that it can last. It is able to last, but it doesn't have to be used over a long period of time. Now, there's got to be some questions about that. There just has to be. Or I haven't done my job.
Can you talk a little bit more about St. Louis? And you mentioned South Korea. Is there anything we can learn
there, but maybe who drove the Choice initiative in St. Louis? How did it come to be? And
well, I again will promise to send you a series of articles about it because it's so important. I mean, I just cannot overstate what an impact this new trial has had. It's like some new cancer drug that's just changing the landscape. It's like, in a way, understanding that SIDS can be reduced by safe sleep. That has, in Syracuse, New York, for example, they've reduced the infant mortality rate an enormous amount. And one of the principal things they did was focus on safe sleep. And it's one of those things that's transformational. It's not just nice. The St. Louis project was started with an infusion of foundation money with a team of people who had long been working in clinical settings. Jeff Pipert is the main driving force, OBGYN, and who just kept noticing that they were just having all these teenagers in particular, but also a lot of women in their 20s and 30s, who still were getting pregnant, even though they were coming to say, I don't want to, I want to go to school, I want to go in this job training program. And they basically were continuing to give them pills and encouraging them to use them, and they had all these, they had electronic packets that beeped if you didn't take, I mean, everything. And then these new devices came on the market, and they said, well, the early data look like they really make a difference. So let's use more of them. But then they did two important things. They said we're going to make them free of charge to the user, because the Affordable Care Act is going to have the same effect in some ways. And we're going to change the counseling and the whole way the clinic is run. We're going to do same-day IUD insertion. If someone says they want it, we're going to do it right there. We're not going to make them come back for 2 more visits or have an STD test and a pregnancy test and then, because they lost women. They said, we're going to start by counseling on the most effective. We're not going to say, here's a brochure with 25 different methods. You take a look at it, read, I'll answer questions, and then you use whatever you want. They started with the most effective, and then, of course, went on as needed. It was not bossy boots. I don't mean to suggest that. And they made the clinic human-centered. They had nice people answering the phone. They followed up. They had 24-hour lines for people if they had questions about these methods. They took them seriously. They treated them with dignity. They originally had to advertise it, and after the word got out, they couldn't keep the women away. Free, terrific care, effective care, ongoing support, unintended pregnancy, teen pregnancy, and abortion. South Korea, I don't know. I have some theories, but I've never even been. We can talk about that. I mean, there are some answers, but I think it's largely about family structure and high value placed on education, but I don't know that. All right. There are, 20 years ago, particularly in the area of teens, but just in general, if people said, I want to put a program in place in my neighborhood to reduce teen pregnancy or unplanned pregnancy, what do you suggest? We'd say, well, we have some promising programs. We've got some ideas, and there's some things that maybe there's been one study done in, Olympia, Washington or something. Right now, the world has changed again. There has been an enormous effort made in the social science community to study the impact and results of a large number of programs. The Office of Adolescent Health, with the help of MDRC, the Manpower Demonstration Research Corporation, very tough-minded people, have a list on their website, and incidentally, that's the second list. That's the second website, so it's on your slide, of effective programs that have been shown by top-notch research, and I mean randomized trial, the whole thing, to do one or more of the following 3 things for the teen ones: raise the age of first sex, increase contraceptive use, and or actually show a reduction in a pregnancy rate, which is hard to show because of the numbers. Our own website also has a list. We use slightly different criteria, but we have where it was done, what the citations are to learn more about it, what the phone number is of the program developer if you want to do it, what populations it was tried out in. Was it urban young women in the Bay Area? Was it rural teens in South Carolina? What was it? So the point is that we now know a lot more about what works. So if you want to do some programming with adolescents in particular, but even some of these span into the young adulthood, don't sit down at the kitchen table and make it up. Use these now really 2 decades of good work to figure out what you want to do. And if you want to make a change, that's fine, but collect data so that all the rest of us nationwide can understand what the adaptations accomplished or didn't. Any questions about that? Or anything else? Yes.
With these programs, does it actually give advice on how to have these conversations with the teens? Because I think, you know, when I have a conversation with my 8-year-old, if I'm going to explain something to her, I'm going to say it differently than I would someone who's in their 20s. And going over this information and saying to a teenager, you know, look at the effects of teen pregnancy, I don't know if that really would connect. So I'm thinking maybe it's something that the task force even could take on, is getting maybe a group panel together of teenagers that suggest best practices on how to connect with teens, and, you know, what's the best way to go about having a conversation. Maybe they create a video even that could be shared with parents and caregivers and employers. Maybe it's at the library, because I just think if you speak to them in their language and connect with them, it probably could have more of an impact.
Well, you're absolutely right that parents talking with young people makes a difference. That's been shown by research, and it's very interesting. We've done many polls all the time of teens themselves, and they say by huge majorities, it would be easier for us to postpone sex, to avoid pregnancy and so forth, if we could have open and candid conversations with our parents or other caring adults. I mean, it's not that long, but to your point. Many of these curricula, many of them are school-based. They do have, for example, homework assignments that the child is asked to do with a parent. So there is quite a bit about that. But what I think I might do, if it would help, is I'll send back to you when I get back a compilation that we have done of tips for parents derived from many of these different programs. I think the key concept that I've absorbed is that parents worry about talking because I think they have to be like a biology textbook. You know what I mean? That they have to know all this stuff, and there's a lot to know and it's hard. In fact, it turns out that the comparative advantage of parents is to be relaxed, to be a source of warmth and guidance. What are our family values? What's our family history? How do we see this? Then there are always materials you can get on all the details. It's more setting expectations and being an askable parent. That's where the magic is, rather than saying, I know the particular side effects of this particular something over here. It's very important. I'm almost done, I promise. The population that is at risk for infant mortality and indeed for teen and unplanned pregnancy goes from mid-teens well into the later 20s and early 30s. Where do those people spend all their time? They are not in programs. They're not in classrooms listening to well-trained, wonderful health education teachers. They are online. And anything that you do or recommend should have a major social media and digital media component. I can't overstress this enough. If you talk to teens, if you ask them about any of this, they probably won't even answer you because they'll be so busy on their phone anyway. And instead of resisting that and saying, well, they make me crazy and I wish they put the thing down and talk to them, we need to embrace that. And I think if we were standing here 10 years from now, the vast majority of education of these things we've been talking about and appointments and everything we're talking about will be done online, digitally. So whatever you do, please think hard about how to use 21st century technology to address whether it's education, support, I understand it's always better to have a lovely person in front of you doing everything, who's well-trained, has all the time in the world, and they're yours. And where that occurs, it's always better than a website. Yeah, 2 minutes, I'm sure it's worse than that. But embrace the technology. And remember, remember, for many people, they would rather do things anonymously, which is what you're allowed to do online, than have to do it in a public setting. Okay, last slide. Please find ways in your recommendations and activities to use your influence. One thing, for example, you may want to do is use your influence to make sure that this kind of a group and effort keeps going. The nightmare is to come up with a lot of great recommendations and partnerships and common understanding, and then it's over. So my first recommendation would be how to sustain this attention. Programs alone are not going to solve this problem. We're going to have to recommend and pursue and dig in on doing many, many things. Use your influence to make an orderly list of things that need to be done, and then an orderly plan for how those actually can occur and roll out over time. That's enormously important. Just 2 or 3 more things that have occurred to me since I've been here and listened to you a little bit. I do suggest you do some very serious mapping exercises of infant mortality in Columbus, where the deaths are, which hospital they were delivered in, where the mother got prenatal care, what the cause of death was, all those things, to get a very rich picture of the infant deaths in this city. I think you should prioritize 4 or 5 things to do. People can't do 28 things. You need to pick a few that are top priority. I suggest you also map services. Many of the infant mortality reduction initiatives around the country, in Syracuse, in Detroit, elsewhere, one of their principal things was to connect the home visiting people and the family planning people, to connect the early intervention, neonatal intensive care, follow-up visitors to other people. Know exactly what you've got and stitch it together. And also in mapping services, I also think it would be very important to assess their quality. Just saying, for example, that a community health center has family planning may or may not mean that they are doing anything about modern contraception. They may be doing pills and condoms. That's an area I know, but don't assume that just because someone says we're doing X, that we now say, well, that's taken care of in that neighborhood. Send people in to assess the quality. I am now done. That's the one. I'm happy to take more questions, although I'm sure I've taken too much time.
Any questions? Any questions for Sarah? So I have to say this last picture on the slide in our book doesn't do you justice.
It's true. I'm sorry. This is Aunt Sarah.
Is that you?
That is.
Okay.
You know, it's fair enough. I just was so terrified by the 1 minute. I do think that there's something about values expressions and sort of normative expressions in shaping things rather than just, we have to get specific on this piece of data. Here's the big picture, in my view. Getting pregnant, or for the gentleman causing a pregnancy, having babies and starting families are perhaps the most important and expensive thing that any of us ever do. Right? Generational impact. It's a big, big deal. And we need to encourage deep thought about when to become a parent, with whom, and under what circumstances. I sort of I wasn't thinking about it, well, it just kind of happened and blah, blah. No, This is too important. I mean, everybody here has an opinion about the March Madness brackets. I often say to people, if we could get people to think as much about pregnancy planning, when to start a family, with whom, and what circumstances, as they have given to predicting Oscar winners or March Madness, we would make some progress. This stuff needs to rise to that level of March Madness and the Oscars. Thank you.
Thank you, Sarah.
I will follow up. Anything you send to me, the email address is here. Any requests you have, we are big on follow-up. As they say, we are here for you.
Thank you, and we will have, I'm sure we'll have lots of follow-up. On the heels of that very informative presentation and discussion, you will find on the last, in your packet, on your table, the very last page of that packet, there's a case study. So hopefully you didn't get rid of it yet. If you don't have that, let us know and we'll get you another copy of it. But there's a case study, and what we'd like you to do is take about 10 or 15 minutes, and at each table review the case study. You also have the resource guide related to both teen pregnancy and family planning that highlights relevant data and key barriers. We want you to use these materials and the presentation you just heard to develop some action items that the task force might consider adopting around this space of teen and unplanned pregnancy using the case study. Number one. Are there two? Whoa. Well, you can choose which one you want to. No? Which one you want them to use?
These two tables do Angela, and the two tables back there do Brittany.
So first two tables do number one, which is Angela, and the back two tables do the second one. Thank you for that call out. I didn't turn the page over. All right, let's take about 15 minutes at the max. We might stop you around 10 or 12 so that we end on time.
So we'll start, Mark, you want to start us off again? You did a good job last time.
In response to the first question about changing social norms, there was support for expanding the Safe Choices program, which promotes abstinence and personal responsibility and safe sex. There was a comment that Angela needs a woman mentor, and that long-acting contraceptions are most effective but not always well understood by teenagers. Second question, what would our community do within school and other settings where we find at-risk youth? There was an acknowledgement that there are a number of after-school programs such as Boys and Girls Clubs that do a good job of involving teens, but it's unclear if they educate teens about their choices or how to prevent teenage pregnancy. Thought that perhaps you could add that component to existing programs. And a note that there's often a cultural clash with immigrant children who have one set of values and their parents who have the value of the home country from which they moved. And then thirdly, what can the community do? The suggestion was incentives for teens to get involved with responsible adults. Is there some way to use cell phones, since it appears that almost every teenager has a cell phone? And is there a way to target information for young men, since so many of the programs are oriented toward young women?
So by incentives, you mean like a cell phone incentive?
It could be different things, you know. What does the teenager appeal? You get a card that is going to let you go and buy music online or whatever it is, you know. If you don't have something for them,
Right.
why would they want to come?
Right. Sounds like you've been around a few teenagers. Okay, great. So we'll stay with case study one, which takes us over to Dan, your table.
Okay, we took a look at this case study and realized that poor Angela has a lot going on here. And there's a lot of chatter from friends, a lot of lack of chatter from parents or caregivers. And we talked about how would we reach Angela. She's not necessarily going to trust an adult. She's not necessarily in school. She may or may not be in church. So how does our community reach her? One of the things we talked about was she's in need of a peer, a mentor, maybe an older peer as a youth mentor, some type of counselor, youth leader, teacher, someone who can reach her with information and talk about what is a good decision and what is not. We also discussed that in this case study and expanding outside of that, education for parents and caregivers is important. A lot of people are looking to the schools or churches to have this conversation when really the conversation needs to start at home. If we can extrapolate from the Start Talking Drug Prevention program, where they say that a child is 50% less likely to use drugs if a conversation is had at home, we're thinking the same must be somewhat true for conception, teen pregnancy. So how do we reach parents? But we think that that's a key part, and talking to parents and making sure, you know, that they are having those conversations. And then the community, again, we were a little stumped about education and access to proper birth control, because there are so many barriers as to where and when and how we can talk about this. But we talked about websites and electronic messaging and ways to reach kids in the means that they're most used to.
Great. Any questions on the first case study? If not, we'll head back to Laurie, to your table. I don't know who's reporting out there.
I'm afraid I am, though it was a very vigorous discussion.
The boss.
And so, first of all, we want to know more, and we want that choice model right here in Columbus. There was a lot of talk about how did that happen, and let's figure out how we can make that kind of availability or that kind of opportunity available right here in Columbus. We also, and you all can read the case study, but the sense was, let's make it easy for women. Here was a woman who wanted to take control, and she knew that having 2 infants already was a big challenge in her life. So make it possible for her to get that IUD or that long-acting protection when she wanted it. So unbundle it, or at least make it possible at labor and delivery. We think that can actually be addressed. And so again, make it easy for women, make it work for her. And I think we heard it from Dr. Fanai, who said make it easy for women when they want that kind of service. So again, we would recommend that we figure out how, with our insurances, to make it, to address the dilemma that the physician explained to her, that they don't get paid separately for that. We also felt strongly that we really needed to support women in being strong, strong and healthy, but to promote strong women, a strong role model, a strong champion. We had 1 vote for Nicki Minaj to be one of our strong role models, but that we have to be very honest about some of these issues about women's health, and yet we talked about being strong because health is not necessarily a big motivator. So maybe strength or activity or something, being in charge of your life might be a better message to go with. But again, being honest, being digital, being smart, empowering women of all ages around these issues. And then we had this conversation that obviously was a part of the Table 1 case studies about health education and where does it need to happen. And we thought in families, absolutely, in schools, absolutely, and yet paying attention to what Sarah shared with us, let's not keep fighting about it. Let's enable youth and women and men, boys and girls, to get that information. So let's go digital. Let's put the information, wrap it around with exciting messages, perhaps from peers, whatever that group. So it could be boys, it could be men, it could be for dads, for moms, for young girls. But let's put it out there, and maybe that will help all of these conversations. Kids know how to get there. We know they do, no matter what their families or their friends are saying. So let's give them a place to give and get great information.
Thank you. And we had a little bit of conversation about this last night, and I couldn't agree with you more and would like to just reiterate, whatever we do relative to informing these teens, if there is not a digital or a mobile element to it, we will not reach them, I can assure you. So that absolutely, Sarah discussed it last night, has to be a piece of this. It has to be easy to get to. It has to be known that it's available. It has to be hip. And it has to be live 24 hours.
And hello? Yeah. And on that, I think it could actually help a lot of parents, a lot of school nurses that I hear from all the time, that they don't either have the time, they don't have the vocabulary, they don't have the information right at their fingertips, which is what both our young people and actually many of us want. We actually shared some personal experiences around the table, so we weren't necessarily teens when we were dealing with some of these issues. And so, again, trying to make that, again, readily available in ways that any of us could use that information, explain it to others, etc.
There are, as everybody knows, applications where you can get help anonymously, to a computer malfunction, to your car won't run, to my rent isn't paid, to anything. And this should be another piece of that. So back here.
All right, so we had Brittany as well. First and foremost, it was unfettered access to birth control. Again, be where the woman is and provide what she needs. And then second was hospital reimbursement, payment barriers and policies, whatever is going on there. Just let's spend some time and unravel and unpeel that onion. Third was appropriate funding for home visiting programs. So now we're getting back into what is the intervention and prevention plan that can be in place. And looking at person-centric, what is the patient system, and what is the post-follow-up care? So if Brittany didn't go in for her post-follow-up care appointment, was there a prompt knowing that baby was born on X date, mom was discharged with baby on 2 to 3 days later, and then 7 to 10 days, if the mom hasn't had the appointment, is there a prompt that's being provided to her in the system? We know our computers and our calendars prompt us all the time for meeting reminders. There has to be a way within a healthcare system for a patient record to prompt certain date times, baby's week 1, week 2, week 3, to flag that system for the follow-up reminder. Or now we go into if the patient was having the conversation at different points of entry, whether it was after the first pregnancy, during that follow-up appointment, or upon entering second pregnancy, education, information about birth control. And Brittany seems to be fairly well informed, just she's not informed in the healthcare system and how it works. She waited until labor and delivery to discuss the IUD with her physician. Is there a way to prompt family structure and planning immediately after the first pregnancy or upon the second pregnancy coming in, talking about what is your family care plan? There's a lot of conversation about what is your labor and delivery plan, what's the post plan, and can that be prompted in the patient record so the physician knows upon arrival of the mom, this has been discussed, is the paperwork completed before mom arrives for delivery? That way it's not put back on the patient for the follow-up. The second piece that we didn't spend time, but you're talking about digital, that's an app. So again, Brittany's fairly well attuned that if you give her information, she seems to know what to do with it. She just needs a little support. So is there kind of a pregnancy app, which I think there probably is now since I've given birth twice? This is what happens during week 1. This is what happens during week 2. Is there a post-pregnancy app that, hey, upon week 1, this is what you may be experiencing with your body, your baby, and did you schedule your follow-up appointment? So is there a way that even the patient then can still take responsibility? So.
Great, thank you. So actually, remarkably similar suggestions if you think about all of the analysis. This will be very helpful in our final recommendation, so thanks to everyone. Well, as we approach 11 o'clock, to be respectful of everyone's time, I'll throw it back to Donna to wrap things up a little bit.
Okay, thanks, Michael, and thank all of you on the task force and the public for your engagement. Again, if you've written down your ideas, please don't discard them. Please give them to either Julie or Jesse or any of the others who are going around the room collecting this information, because it's a lot of good data. We've got this stuff recorded, but sometimes what you write down, especially those of you in the room, will be very important and informative for us. So our focus today has been on preconception and interconception health. We've identified some real opportunities to get more women enrolled in health insurance and connected to ongoing sources or primary care. We've also discussed considering awareness and educational campaigns, some digital, some through the normal channels around preconception health, and that may start with, of course, women in school and possibly some women outside of school, understanding we do have systems where there are individuals that are not inside the systems and we're trying to get them back in. We've talked about the need to think differently about how we interface with healthcare professionals, those especially who provide preventive services to women, that tools and resources do exist to help them treat every encounter as a preconception health education opportunity, but we have to make sure that the payment models are aligned, and that's very few words around something that is huge in terms of alignment of payment models. So we scratched the surface on that, so I hope there's more to come as we move forward with recommendations. Related to family planning and prevention of teen pregnancy, we could pursue changes with Ohio Medicaid to enhance reimbursement that eliminates existing barriers and creates supportive policies for family planning services at the time of delivery. Along with that, we talked about the need to make sure women are educated and about the importance of adequately spacing their pregnancies and have access to family planning services to avoid unplanned repeat pregnancies. There are a number of things we can do to avoid unplanned pregnancies, implementing evidence-based teen pregnancy prevention programming. Sarah was very helpful in shedding a light quite simplistically but effectively on some of the things we can do and that are being done in other communities. Using media, we've touched on that on a number of areas, but especially for our teens. And increasing access to long-acting reversible contraceptives and other contraceptive options to sexually active women and teens. You know, this is the conversation that is a tough one to have, but we have to have it, and while remaining respectful of differing points of view. So I hope as a task force we continue to be courageous as we are considerate in these discussions and putting the access to these tools on the table in the appropriate way. Any other big ideas that I might have missed? Okay, before we wrap up, staff has been hard at work, so just in the time from the start of the meeting to now, they've set up several more workshops to convene groups and stakeholders. There will be a workshop on March 26th from 9 to 10:30 at Nationwide Children's Hospital. These will be on the website, and we will communicate this to task force members because these are opportunities. I'm just going to highlight them. Opportunities for you to engage and to be engaged with the community. One planned for educators on April 2nd from 3 to 4:30. Another planned with social service agencies on April 11th from 2 to 3:30. Another with our faith leaders on April 21st from 12:30 to 2. So those are four. More details will be communicated to you directly and on the website, and more to come in terms of the community engagement and engagement with key stakeholders around solutions and recommendations. So, hearing no other closing items or remarks, we'll be back at this again. We only have 9 days until we see each other. I know that seems like a short time, but we will miss you. We'll be back at Nationwide Children's Hospital at 9 a.m. On March 21st. And if there are no other comments, and I'm looking to my right to make sure we haven't missed anything, I don't think so. I want to say thank you, task force members and the public, and we are adjourned.